Okay. Good morning once again, everyone. I'm going to talk about the third space endoscopy, and this actually sounds like a fancy title, but it conceals a wide range of really great technologies. So we want you to look at this picture. What do we actually see on this picture? This is so-called third space. So in my presentation, I will cover two things. What do we actually mean by the third space, and what can we do in a third space? Until recently, the endoscopic surgery meant a work in the two main anatomical spaces. Intraperitoneal space, that is the space inside abdominal cavity, and endoluminal space, that is a space inside the hollow organ lumen. And the ideology of some kind of third space located in between these two gave a start to the new era of endoscopic surgery and opened the door to a wide range of procedures which do have one thing in common: a work in a basically new artificial space. And the third space endoscopic surgery, also known as submucosal surgery, is based on the principle of approach to the underneath anatomical structures of GI wall by means of tunneling dissection. So that is creation of the tunnel with no compromising of mucosa, except the entry to the tunnel. From classic hydrodissection to the new technologies of the tunnel creation using balloons. In such a way, all techniques related to the third space endoscopy, like listed on the slide, in fact consider a work in the submucosal space. Needed to say that despite the fact that the third space endoscopy is relatively new and modern direction, we can watch the evolution already. Historically, the third space endoscopic surgery started with ESD technique, with the main benefit of getting a one-piece specimen of mucosa and partially submucosa in order to be able not only to remove the lesion completely, but also to get a good assessment of vertical invasion on pathomorphology. And firstly done in 2008, POEM was based on the existing principles of treatment of achalasia. Firstly, cardiomyotomy, also known as hilar myotomy, and secondly, the same technique principles as in endoscopic submucosal dissection. And today, POEM could be considered a gold standard in the treatment of achalasia with a proven efficacy and low incidence of complications. And this year, it's a 10th anniversary of this technique from the first published data. And these are the steps of procedure. And today, 10 years later, we've got a lot of techniques which are derivative of the POEM procedure with different applications, like, for example, pyromyotomy, also known as G-POEM or gastric POEM, in the treatment of pylospasm, gastroparesis, and other gastric motility disorders. And also underlie the submucosal myotomy for Senker diverticulum, also known as Z-POEM, or D-POEM for other diverticuli, with the same principles of surgery, dissection of muscle fibers in submucosal space. And also underlie the technique of PREM, perirectal endoscopic myotomy, which is myotomy technique performed for Hirschsprung disease. And we do have a publication of a few clinical cases with the preliminary results on humans, with the same steps of surgery. But the successful application of the third space was not limited only by submucosal myotomy. The creation of such a long tunnel needed for subsequent myotomy in POEM procedure underlie the next technique, which is STAIR technique, a submucosal tunneling endoscopic resection. And the first step is pretty similar, consisting of submucosal injection, opening of mucosa in a distance from the tumor, and the steps of tunneling creation and the steps of submucosal dissection until complete removal of the tumor, as you can see on the video. So we do the same approach. We inject into submucosa, we open the mucosa a little bit in a distance from the tumor, and we start to perform a dissection in the submucosal space in order to create a tunnel. And in this tunnel, we remove a tumor by completely mobilizing it from submucosal space. And then we remove the tumor from submucosa and we close the opening of mucosa by endoscopic clipping. Here you can see the steps of submucosal tunneling, endoscopic resection. And the principles are the same for all these procedures working in the submucosal space. And talking about new technologies and future perspective, we can say that today we do have a lot of techniques which are still under development. And here on the slide, you can see the different types of procedure, like the biopsy of the nerve and the muscles, which is the future technology in the diagnosis of different gastric motility disorders, or harvesting tissues like stem cells, or, for example, placement of stimulating and monitoring devices, which are using for different gastric motility disorders and even in the treatment of obesity. So there is some data published recently about the tissue samples from the submucosa, for example, for submucosal non-epithelial tumors, as we discussed yesterday during the GIST session. And, for example, the data published on the work with the stimulating device implanted into submucosal space for the treatment of different gastric motility disorder, like gastroparesis and others. And to conclude, I want to say that the third space endoscopic surgery is really evolving technology which include more and more new techniques every day. So the initial results are very promising, and the future experience is needed for analysis. And of course, training of advanced flexible endoscopic skills is essential for surgeons. Thank you. So I will be happy to answer questions.
Есть ли вопросы какие-то в зале?
Большое спасибо за выступление, очень интересно. Вопрос такой. Традиционно в России сложилось разделение на хирургов и на эндоскопистов. Вот на ваш взгляд, вот этими процедурами кто должен заниматься, хирург или эндоскопист?
Эндоскопический хирург.
Гибридный.
Обладающий продвинутыми навыками оперативной эндоскопии.
Гибридный хирург.
Опытом, прежде всего, выполнения эндоскопической диссекции по слизистым слоям.
Спасибо за прекрасную презентацию. Какие бы вы хотели выделить показания для тоннельных операций при подслизистых образованиях? Это зависит от размеров, от локализации.
Прежде всего, это зависит от характера образования. Те случаи, когда мы подозреваем, что это может быть гастроинтестинальная стромальная опухоль, абсолютное показание к ее удалению. Если диагноз непонятен, пациент канцерофобичен, тоже это повышает показания к тому, даже если есть подозрение, но это на дооперационном этапе не точно. И, конечно, это образование доброкачественное, в том числе, которое располагается в анатомически сложных зонах. Это образование больших размеров, которые вызывают клиническую симптоматику. То есть обструкцию, прежде всего, это пищеводно-желудочный переход, это область привратника. Тогда мы можем удалять и липомы таким образом. То есть доброкачественное образование, которое, в принципе, не показано удаление этих образований.
Ну, вот если сантиметровое образование удаляем?
Если это гастроинтестинальная стромальная опухоль, да,
Нет.
потому что в настоящее время доказано, что даже при таком размере образования индекс может быть высоким методической активности. Если это липома или миома, то мы не удаляем это образование, подлежит динамическому наблюдению, естественно.
Наблюдать, да?
Конечно. По всем международным рекомендациям, да.
Спасибо.